Hello everyone, my name is Cheryl Fatibene. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar, Delivering Culturally Sensitive Care to the LGBT plus Patients by Dr. Jessica Landry. Dr. Landry is a professor at LSU School of Nursing. Today's webinar is being recorded and will be available in the upcoming week on our NPSAN portal page, and a link to the recording will be sent to all of you who have registered and are on the call today. All participants will be muted throughout the presentation. I encourage you to submit questions during the presentation. Please use the Questions tab on your GoToWebinar panel as seen here to ask your question. It will be relayed to the presenter and answered at the end of the webinar. A survey will pop up at the end of the webinar as well and will be sent in an email later today. Please take a few minutes to complete the survey evaluating this activity, as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available to you as a handout, which you can access via the Handouts pane on your control panel seen here. You can click the name of the handout and it will be downloaded via your default web browser. Let me take a quick moment to talk about the national investment taking place for quality improvement in the United States with the help of the federal government and the organizations who are presenting this content as part of the Transforming Clinical Practice Initiative, which is sponsoring today's presentation. The Transforming Clinical Practice Initiative, or TCPI, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and the enrollment of 150,000 plus providers across the country. The NNCC, or the National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and to meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional membership organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 72,000 members and growing. CMS funded the NNCC and the AANP to support enrollment of nurse practitioners into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational material, including this webinar, that facilitates practice transformation in advance of upcoming payment reform changes with CMS. The AANP and the NNCC are the only nursing-focused grantee of the TCPI project. The NNCC and AANP agree that this initiative is important to ensure that NPs receive the support they need to remain competitive in a changing healthcare landscape. Nurse practitioners are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for NPs to prove it by helping CMS and the broader healthcare community build the evidence based on practice transformation while preparing for value-based reimbursement. So how do we prepare NPs for upcoming value-based reimbursement? We want to use this program to prepare clinicians across the country for payment reform under MACRA, the Medicare Access and CHIP Reauthorization Act of 2015. As many of you have probably heard of MACRA, it is legislation that was passed to establish Medicare's Quality Payment Program, or the QPP. Under this Quality Payment Program, there are two payment adjustment mechanisms to incentivize quality tied to Medicare Part B payments, MIPS, or the Merit-Based Incentive Plans, as well as the Advanced APMs, or Advanced Alternative Payment Models. Most clinicians, including NPs, will end up associated with the MIPS, or the Merit-Based Incentive Plans. MIPS involves 4 elements that clinicians will be able to successfully demonstrate in order to maximize their Medicare Part B payments. These elements are quality, the use of resources, identifying clinical practice improvement, and the use of health IT effectively. If you can demonstrate these 4 elements in your practice, you can succeed in a value-based payment environment. We know NPs have a large growing role in the delivery of health care, especially primary care. The NNCC and the AANP want to connect NPs to TCPI-funded practice transformation networks, or PTNs. There'll be more information about that at the end of this presentation. These peer-based learning networks have the responsibility for enrolling and supporting clinicians. They provide boots-on-the-ground technical assistance and services to help realize practice transformation. How can we as NPs help the PTNs by serving as leaders in their networks? We have experience, we know about collaboration, we're interdisciplinary and often work in team-based environments and can be leaders in this movement. I would now like to turn the presentation over to Dr. Jessica Landry. Jessica?
Hi, thank you all for having me. It's really, truly an honor to be able to present this to you all. And thank you so much for all of you for signing up for this webinar. It's a large number of you, so I appreciate you. Let me just start by saying that this presentation is very important to me. I've been a nurse practitioner for about 15 years, and I've worked a lot of that in an emergency room. And one day, I was challenged with taking care of a suicidal transgender child, and I really felt like I didn't know what to say. I didn't really know how to reach this child, and I felt in some ways I sort of let him down. It wasn't a successful, I don't think, interaction with him. And so I started doing some research and learning about this group, and also as an instructor of nursing, I really wasn't teaching the importance of communication and respectful communication and the intricacies of their culture. And so I did some research on it, and I'm proud and very happy to present it to you. So the goal of this is to help you to develop a relationship with your LGBT plus patient, help you to know what to say or how to reach them in a better way, help them to figure out where they're coming out maybe in their coming out process, and how to support them and be a support system for them as a provider. I'm ready. First of all, just a little background on it. We don't really call it homosexuality anymore. That's not what it's called, and we'll go over some terminology later. But early in the 1800s, and even before that, it was never considered to be anything abnormal. That human sexuality varied, and it varied across the lifespan, that it wasn't something that was a dysfunction or a disorder in any way. Next slide. So back, not only did our Freud and Kinsley and other psychiatrists and sociologists here study human behavior, but also Hirschfeld back in Berlin did lots of research in Germany prior to World War II, and really found again that across the lifespan it was normal. It really wasn't until World War II that this group of people began being persecuted and began being biased, seeing bias and prejudice against. Hirschfeld had a huge library in Berlin that was burned down by the Nazis in 1933. Next slide. It would really be nice to know what he studied back then. If we only had an internet, we could go back and see all that. It would be awesome. Anyway, it continued even after World War II. As everybody probably knows, the apartheid movement came in, and what was happening in South Africa to all the South African people, but lots of their defense forces, the military, the gay men in their military were removed from service and put into prisons, and they were tortured in many cases that resulted in death. Next slide. So one of the biggest protesters to the apartheid movement was Archbishop Desmond Tutu, and he went in and certainly won a Nobel Prize for all of his efforts against such discrimination against others, in particular inequalities of those suffering through that, including the LGBT population. Next slide. And then later on, his daughter decided that she wanted to fall in love with, and he supported her lesbian marriage and still does today, even as Archbishop. So the stigma faced by the LGBT community remains today and all over the world. Next slide. So what does this all mean for us? Why are we sitting here today at this Lunch and Learn and really learning about this? And it's really because as nurses, I feel that it's our duty to try to reach patients where they are. And a lot of these statistics are really staggering. We need to realize that 74.1% of LGBT students are harassed in our schools. That's a huge number. As nurses, these patients are coming through our clinics, they're coming through our hospitals. We're seeing them, but we're not picking up on it, and it's leading to health disparities, or we're not picking up on it enough, and it's leading to health disparities. 90% of these students feel distressed during their time on campus, and you'll see that later on. This contributes to a lot of their suicide attempts. 30% miss at least one day of school due to harassment or bullying. We should be doing more screening in this population of people. Next slide. Early detection is really the key. Waiting till they're in the ER in terrible condition is not the time to intervene. Well, we have to intervene then too. It just would be much more productive if we could intervene before. Continuing on, of 6,400 transgender and gender nonconforming people, 78% harassment, 38% physical assault, 12% sexual violence, and 15% of this group just quit school completely due to a sense of threat. Next slide. So as nurses, this affects the psychological health of our patients, and we really should be screening for this. Discrimination also continued into the workplace. So this goes into our adult population of people. 90% of those surveyed reported examples of harassment and mistreatment in the workplace. This is a very, very large number of people. Only 10% didn't feel that they were threatened in any way. Of the economically disadvantaged patient, 19% were refused home rental, apartment leasing, and found themselves homeless at some point during their life. They also reported, if you look at the bottom slide, outright refuse health care due to their sexual orientation. That should be a huge red flag to us. These people are going around and being possibly refused, 19% refused health care. Next slide, please. So of the disadvantaged population, lots of them sought asylum in homeless shelters. Some of them were outright refused shelters, and 22% were assaulted either by shelter staff or residents. Next slide. And here's where the suicide attempts really make a difference, and something that as nurses we should be watching for and screening for. From grades 9 through 12, and then this is our PEDS population, but 14.8% of heterosexual students attempted suicide. So we know the suicide rate in this age is higher than normal, but 42% of lesbian, gay, and bisexual students attempted suicide. That's a huge number. Twice as many. So we really need twice as many gay and lesbian and bisexual students were threatened or injured on school campus with a gun, knife, or a club. Again, just something for us to be very aware of in our attempts to reach these students and prevent health disparities in them, and realize where their mental health is and how do we screen to prevent suicide. Next slide, please. And then it just continues on. 2015, more likely to feel sad or hopeless, be victims of sexual violence, use drugs, and experiment on drugs. And these rates are even higher in transgender patients. Next slide. So in 2015, students who reveal their sexual identity, their sexual identity were much more likely to suffer from physical violence. And a lot of psychological textbooks and stuff that we still learn from and teach from still have an ICD-10 code for this. It's called gender identity disorder. So that kind of gives us even more confusion. You may see a diagnosis on this like that as a disorder and think that there may be something wrong, when really it just creates more confusion. Next slide. So what are we doing to contribute to these disparities? And I don't think that we're doing it in an intentional way at all, but we are not addressing their concerns. They feel invisible to us. And I go back and I think about myself interacting with this transgender child that I sort of felt uncomfortable. I was afraid that I was going to say the wrong thing to him. But in my quietness and my retreat, out of fear of offending him, I might have appeared invisible to him. So when I saw that word invisible, I thought, well, how many more of us are out there thinking that, holding back conversation because we don't want to be offensive. But this don't ask, don't tell model that we're doing completely unintentionally is really contributing to a lot of the health disparities that are seen in this group. Next slide, please. So LSU School of Nursing developed an advocacy program, and I am very happy if any of you all want to contact me after this or know somebody who would be interested, we can travel to you, or you can come here to New Orleans if you would like, and we can do a 2 to 4 hour training course. It's sort of teach you how to incorporate a safe place and ways to communicate with patients, and how to create inclusive environments within your either hospital, your organization, your clinic, wherever it is that you work, just so that your patients can feel better and your staff knows how to intake patients and how to ask the right questions with the sexual history and those kind of things that we're about to get into now. So we're happy to come to you. Email me if you are interested. Next, please. So before I began this research project, and we've done quite a bit of research on it so far, but in the early stages, I've looked at interviewing doctors, nurses, nurse practitioners, even some PAs, and I asked them, I said, how do you feel about getting education in LGBT patients and just creating that inclusive space for them? And overwhelmingly, I got the statement in red. I don't need that. I treat everybody the same. And so it kind of got to me, and I was, really, do you mean you really treat everybody the same? And so my next question was like, well, you don't treat an elderly person the same as you do a toddler, do you? And they would, of course, laugh and say, well, no, of course not. That's not what I mean. Okay, so what do you mean? You mean that you treat everybody respectfully. And I think that's what most of us mean. That's what we all try to do. Certainly we don't go to work trying to offend anybody. But I think if we don't understand a culture, it's hard to be respectful. If we don't understand diabetes, how do we really treat it? So I think understanding and education is really very important in making a difference. Next slide, please. So, and I talked a little bit about this already, but the religious beliefs, we're taught these in school. We know that, you know, blood products and Jehovah's Witness patients to be respectful of that or breach that. When I worked with women, would do pelvic exams on Muslim women, we were very, very careful in draping them and who was in the room with them. And when we care for other vulnerable populations, there's a lot of information, and now more textbooks are coming out with information on LGBT, but it's not always covered. When we first started this in our nursing school, this type of education was nowhere in our curriculum. Then when we introduced it to the med school, it was nowhere in their curriculum. So now we've got this threaded through both the nursing school and the med school, and it's now getting into the allied health professions as well. So just being mindful in the need for it is also important. Next slide, please. So creating inclusive spaces, that sounds really easy, and it really isn't hard to do. You just have to know how to do it. And sometimes LGBT patients do not seek health care out of either bad experiences, maybe they feel like they have limited access, or just that they fear the lack of knowledge and experience of the healthcare professional. And if you look at some of the data that's out there, lesbian women are much less likely to go in for mammograms and pap smear screenings, and their cancers are caught at much later stages. So it's very important for us to create these spaces. Next slide, please. So how do we do that? What's some ways that we do that? When you're unsure, one of the basic things is, and I know this is kind of like simple information, but we have to already know that we probably already have heard or made assumptions and have heard stereotypes and have seen that, and it's just part of the culture. So we want to be aware of those. That's one of the things that we do in our training, is teach people how to be aware of those stereotypes and assumptions that you make. And so that's the first thing you want to do, is first be aware of the assumptions and the stereotypes. And when you don't know, just ask them, what pronoun would you like for me to use? If you're not sure, if they do have a gender fluid appearance, and we'll get to that in a bit, ask them, what pronoun would you like for me to use? They might say they, and you just use the pronoun that they say. But please document that so that other people coming behind you can also remember, and not everybody's asking what pronoun because that shows it exhibits concern and respect. Okay, so they're going to make a note of it and remember next time I'm here in this office. Next, please. So one of the things that you can ask if they come in and their name may not match their record is, could your chart be under a different name, or what is the name on your insurance card? And a lot, it's really not recommended to ask for their real name. What's your real name? And it shows that you're not respecting that the name that they want to go by is their real name to them, even though it may not be the legal name. And so why do some people not change their legal name? And I have a transgender friend that comes in and gives talks for us when we do our advocacy training, and he does such a good job of explaining it. And he'll tell you, he says, I don't change my name because he's female to male transgender. And he says, what if I would get put in a male jail? What if I would get arrested for something and they would put me in a male cell, holding cell, with other men? And I thought, wow, absolutely, everybody can see the dangers in that. Other things with it too, maybe insurance carriers, if they're registered as male, pap smears or things like that may not be covered. Something too to consider if you're not familiar with the transgender, many of them don't elect to have bottom surgery, so they may still need pap smears, or if it's a female, or need ultrasounds, and still may develop ovarian cysts and things like that. And it's okay to go there with them and explain that you need to do a pelvic exam. Just do it very respectfully. Next slide, please. So beyond having an environment, an open environment, you certainly want to remain open and non-judgmental. And again, that always seems easier said than done for people to not be judgmental. One of the best ways that I've found to do that is just to know yourself and just to be as self-aware as you possibly can and sort of move on from there. Some best practices include just really open-ended and general statements. The more general you go, the better. Let them do the talking. That way, you're addressing their needs, and you're also allowing them that time to establish rapport, and you're giving yourself the opportunity to establish rapport with them. So one question I like to ask if it's a sexual issue or what have you is, what does safe sex look like to you or mean to you? Because that could be different and mean a whole lot of things. A lot of our younger populations are using anal sex instead of vaginal sex so they can not get pregnant or remain a virgin or those kinds of things. So opening up the questions like that, what does safe sex look like to you, lets them then talk and open up to you about what it is that they're doing. Same thing about partner and marital status. Don't assume that they're married. If it's a woman married to a man, ask questions. Who lives at home with you, or who is family to you? This is also important in the PEDS office. When a child would come in, you don't want the child to, if you ask the child, where's your mom and dad, this child very well may have two dads or two moms. So be mindful of the questions, how specifically you ask them. So in general, go general. Next slide, please. So really, whenever you're able to elicit honest answers from your patients, you are much better able to determine what screening tests you need to order for that person and not miss anything. What relevant education information that you could provide, anticipatory guidance for them as well. And you can also just overall, hopefully the whole goal to all of this is to improve some of the health disparities in this group of people. Next slide, please. So if you are having to take a sexual history, one of the 5 Ps is what's really being pushed to ask. So partners is, who are your partners? Practices, what does safe sex look like to you? What is your practices? Past sexually transmitted history, protection from sexually transmitted diseases, and pregnancy plans. So you certainly, even if your patient is LGBT, you still may want to ask about this. There's lots of couples that want babies that are same-sex couples. So this is certainly still an appropriate question to ask. Next slide. So this is the Caste model on coming out, and this is important, I think, because our patients can be anywhere with this Caste model, and this is an evidence-based model. You can certainly look it up if you like, but so usually the very first, I guess, transition or whatever that they notice is confusion. Then they begin to compare themselves to others. So that they're confused, they're not sure about what's going on. Other people look different to them. They begin to compare then. And then at some point along the process, they learn to just tolerate themselves. This is how I'm going to be. I just have to accept it. I guess I just have to accept it. I'll just tolerate it. Then eventually they get to the point where, okay, I'm good, I guess. I'll just accept this is what I am. This is what my life is. Then the next step is pride, and you see that a lot, particularly here in New Orleans. We'll have gay pride here and all of that. Nothing's wrong with pride, but pride sort of limits you to just the group of people. I'm proud that I'm gay and or lesbian or whatever group that you associate with, but then it's only that group. Synthesis is the part of the model where you're really found your way in society as a whole. I'm just fine. I am who I am, and I'm good with it, and I'm fine, and I don't need to just belong to a small group of people. I can belong. I do belong. And synthesis is also kind of like, I use this example in research as well. At the end of your research, or at the end of whatever your project was, you synthesize it, you do something with it. And so I'm hoping that all the work that I'm doing helps to sort of come together and improve overall the outcomes in their health. And so synthesis is, you want something good, hopefully, to come out of all of it. Now, our patients can go from different stages to different stage. Some studies show that if you can catch people in the comparison, in that comparison stage, and that confusion, they may not be open about being confusion, but somewhere between comparison and tolerance, and show some acceptance, show some open and make inclusive spaces to that person, you can a lot of times decrease a lot of the mental health problems, the suicide rates, those kinds of things, if they're shown support early on in the coming out process. So that's something to consider as well. Not everybody makes it to Pride and synthesis. That's important to know as well. Some people live in that confused comparison or tolerance stage for most of their life. Next, please. This is the gingerbread person. I like this little picture. It's easy. It comes from my friends at the Gay Alliance, which I want to make sure that I mention them later at the end as well. But this is a gingerbread person. And what this is representing to you is how a person identifies, male, female, or both, which people can identify as neither one. They can just consider themselves neutral, is not necessarily related to who they're attracted to. So their brain, their identity may or may not, they can certainly be a man and be attracted to a man. They could be a man and be attracted to a woman. They could be a man and be attracted to both. It doesn't necessarily have to be one or the other. The way they choose to express themselves outwardly, again, does not mean that they have to identify that way. An example of that is drag. A person that is in drag may identify, let's say it's a gay man or a gay woman, and choose to be a drag king or a drag king as an expression. They are not trans. They do not want to be trans. They don't identify as trans. However, they're going to express themselves in this way for a show or for entertainment or for fun or for whatever the case is. So again, just because you see a drag queen doesn't mean that that's a transgender person. Doesn't have to be that way at all. And then their sexual genitalia. All of these things, although traditionally the binary way that we've always thought about it traditionally is that if you have female genitalia, then you should identify as a female, you should be feminine, you should be attracted to men, and you should express yourselves in dresses and earrings and makeup. So that's really the binary, of course the same goes for the masculine male. But the idea of gender fluidity really is that people don't always fit into that box. And we talk about tomboys and things like that. People don't always fit in boxes. So it's a continuum, if you will, of where patients or people in general, who they love may be different from their genitalia. So it's just a non-traditional way of looking at a person. Next slide, please. This is an example of what a gender fluid person may look like. They're attractive either way, and they can pass for either way, and that's something that is very important, particularly in the trans population, is to pass. They certainly want to pass for the gender that they most identify with. That does not mean that that trans person, if they're dressed, they can be attracted to either male or female. Let me give you an example of what I mean. Next slide. I think it comes on the next slide. Yeah, here we go. Okay, let's go over just some terminology. And this is a very brief overview of the terminology. If you were to take the advocacy course, we would get into much more detail. Or also, if you're interested, you can go to the gayalliance.org, and they have a safe zone training that you can take. You can go to Rochester and take it with them, or they can come to you wherever you are and receive the training to become a safe zone trainer. And in those, they go through so much more, in so much more detail about the different terminologies and different activities that you can do. So the Gay Alliance has been a huge I guess, mentor for me in this process. And so I certainly encourage you, if you don't have Safe Zone where you are, or you think that Safe Zone is needed, to reach out to them. They're a wonderful group of people to work with, and they're willing to help you. So let's just go over just some of the vocabulary that you may hear. Heterosexism, that sounds like a funny word, but I think this goes on all the time, unintentionally. Sort of society thinks in a heterosexual way. In other words, we just make these assumptions about people. We assume that if you're female that you're married to a man. We assume that if you're a child you have a mother and a father. We assume that if you're a man you have a wife at home. And sort of society will kind of revolves around this idea of heterosexism. And that sort of singles out the LGBT group because they don't necessarily feel in a lot of ways sometimes discriminated against because of this heterosexism. I don't think this is always an intentional thing. Is it sometimes intentional? I'm sure. But most of the time, I don't think most people even realize it's going on. So something very important for us to be aware of. Also the term intersex. We used to use the term a long time ago, gosh, when I was in nursing school, as hermaphrodite. That was the old term. That is no longer used. The more correct term is intersex. And then I was talking to one of the physicians, faculty here, and he was saying that this term is also being revised now to be more inclusive, and I'm not exactly sure what that term is going to be, but there's some talk about not even using intersex anymore, so just trying to keep you as updated as I can. But this is a person who's born with different genitalia, maybe ambiguous genitalia. Maybe they have, you know, one undescended testicle and an ovary, or what have you. Just, we're not sure. And so in the past, what's been done is you just made the child into whatever they most closely resembled. The push now is to not do that, obviously. It's to let the child reach an age where they're able to tell you who they identify or what they identify as, what gender, if they identify with the gender. And I'll have a story at the end to share with you to kind of show you how young this really does occur. We don't think of it that way, but if you look at some sociology studies, it certainly does occur very young. And back to my example that I wanted to give you before when we were on the slide before about gender fluidity, is this pansexual term. I have an example to give you about that because I couldn't quite wrap my head around that one. I have a friend that she was a lesbian with another. There were two lesbians, and they were in high school together, and was always a couple. And then later on, while in college, one of them decided that they wanted to be trans. She wanted to transition into a male. So her partner stayed with her through the transition. She is now the partner. They're still together. Her partner has transgendered into a male, looks like a man. They are still a couple, and they actually have a baby now. They have a brand new baby. So would you consider this to be as pansexual? She loved her as a woman. She loved her now as a man. It had nothing to do with what they look like or what kind of genitalia they have or whether she had surgery or not. It didn't matter. She loved the person for the person. And so that's kind of an example of pansexual, that not necessarily about anything outward and more about who the person is on their own. Genderqueer, an example of well, I don't have an example of genderqueer, but genderqueer is somebody that is non-binary. They don't necessarily identify as male, female, lesbian, gay. They're just in the middle. They may refer to themselves as they or they, that they may actually be their pronoun, and that's how they identify. And then queer, that was a term when I was growing up that we avoided at all costs. We didn't use that term queer. It would have been sort of, derogatory from where I live or part of the country that I grew up in. And now we're finding that lots of people, especially younger populations of people, may very well identify as queer. And so if they tell you that they're queer and that's how they identify, then it's okay to use that term. I wouldn't assume that term, but if they outwardly tell you that's what they are, certainly be respectful in that. And then two-spirit. Two-spirit is an old Indian term suggesting that someone has the spirit of a male, female, and this was not a derogatory thing. This was actually a special gift that this person had, to be two-spirited. And then I think transphobia, I think that sort of speaks for itself. I think that people can be fearful of what they don't understand. I think that's true in a lot of different scenarios, but when we're talking about people and we're nurses talking about people, we really shouldn't maybe have a phobia against another person. We should do our best to understand that society, that this may exist in society, and how can we make this patient, I should say, feel more comfortable and accepted into our hospital, our clinic, wherever it is that we are. So know that that's out there, and that transphobia certainly contributes to lots of health disparities in this population. And I'm hoping that as nurses, we step up to the plate and just create inclusive spaces so they're not afraid of expressing their mental and physical health and sharing that with us. Next slide, please. So I wanted to bring this up because this certainly is all over the news now, just about trans people serving in our military, and wanted to point out that 18 countries certainly do allow transgender people to serve in their militaries. The healthcare costs that it costs the United States each year to care for transgender patients is between 2.4 million and 8.4 million every year, which when you look at the healthcare military budget, it's about 0.04 to 0.13% of the military healthcare budget. Overall, the United States spends about $700 billion in military defense. So I just wanted to put that out there. Those are just the statistics. Next slide, please. I would like for you to watch closely to this video. It's very important to me. It's very touching. Okay, was everybody, I don't know if everybody was able to see it.
We have some people on the line who said they were not able to see it. So what we'll do is we're going to copy and paste the link into the chat box for everyone afterwards. It's definitely worth watching. So you can go ahead and continue, Dr. Landry.
Yeah, I am actually done with my presentation, and I can take questions now, the last 15 minutes if you'd like.
Okay, we have up on the resource slide, you had talked a little bit about the Gay Alliance and the safe zones, and I was wondering if you could speak a little bit more about those and how that works.
I think it's on the slide right before that one, the like go up, back one. There you go. That's actually the web address if you would like to have any information at all about Safe Zone. Gay Alliance does a lot of things. They're a nonprofit organization, and they support LGBT patients and people across the United States. They do go to you, like say you want to have a Safe Zone training session, they will come to you if you have about 25 to 30 people that are interested, and do what's called a Train the Trainer course. It's an 8-hour day where you sit and you learn a lot of the things that I talked about today, in that you can use these Safe Zone stickers in your hospital, you can use them in clinics, you can use them in schools, and basically you have a sticker that you put on your door, on your window, wherever you are, a lapel pin, and basically it communicates to LGBT patients that you're a safe person to go to if they're having any issues. It's sort of just kind of a symbol, if you will. And LSU School of Nursing has worked with the Gay Alliance in developing the Advocacy Program, which is sort of like a Safe Zone, but specifically for healthcare providers. We've had some docs and nurses and nursing students and nurse practitioner students go through it here on campus, and we are working our way to other Louisiana campuses. It'll be very, very interesting to get the data on that, because here in New Orleans, everybody's attitudes were so great, you know, and positive towards the LGBT community, it's going to be very interesting going closer to the Bible Belt and comparing those results to see, and I'm sure the approach that we take is going to be a bit different as well too. So we're looking to do that and branch out to places where maybe LGBT patients are underrepresented or going unnoticed like that, and kind of bringing that awareness to nurses and physicians.
Okay, we're going to move forward, and these are references that are showing up on your presentation here, and they're available for everybody through the handouts again on the handouts page in your web browser. You should be able to download that. So we do have some questions that are coming in from the audience. Generally, we're just seeing a lot of thank yous and kudos on the video. I'm very happy that it was well received. I think it's an excellent video. I know it was very touching to watch. So one of the first questions we have comes from Rachel, and the question is, how do you recommend approaching patients with regard to their gender identity and sexual identity without necessarily singling them out, that they may be one way or another, because we don't want to re-emphasize any assumptions? Any suggestions on how to do that in a sexual history or in general?
Absolutely. I think that one of the things is really talking privately to the patient, but it's really not wrong to ask them, what is the pronoun? What pronoun would you like for me to use? How would you like to be addressed? And it's been my experience that when you do that, patients are really willing to tell you, because they almost want you to ask. They want you to acknowledge it and not make that assumption. So just by simply saying, what name do you prefer, and what is your pronoun? What pronoun would you like for us to use here while you're in our clinic, or while you're staying here on this unit, or wherever your work facility is? And then I would really encourage you to write that down on a chart somewhere, on something. I had one patient that was intersex that his first initial, he was appointing, well, he had an appointment to a GYN clinic, and he walks in and he's dressed like a male, identifies as a male, but he's there for a GYN exam. And my clerk looked at the name was a male name, and then in the middle of this waiting room with all of these pregnant women and other women waiting for their GYN exams and breast screenings, looks at him and says, you know, this is a women's clinic, right? Like, I mean, just in front of everybody. And it was just very, very traumatic to the patient. And so when I realized what she had done, I went and got the patient out, brought him in a separate waiting room, and then told him from now on, I apologize for that happening, obviously, got how he wanted to be addressed, talked to him about waiting in a separate waiting room. Would that be more comfortable for him than having to check in at the front desk? And the answer was yes. So from then on, I just instructed the people in the front, when, I'm not going to use his name on this webinar, but when he comes, you do not need to check him in. Just let him go straight through the double doors into the private waiting room, because walking through the waiting room, people in the waiting room could have thought that he was just a worker or a drug rep or whatever, not being having to sit there and wait with them in a chair. So he would just walk onto a private waiting room and wait until I would call him personally. And he would show up every year for our screenings, and that was just really important. So it's just, sometimes you can catch it right away, sometimes you can't, but having the conversation privately and asking them is already showing respect.
Thank you. Quick question from Judith about the term LGBT, and what would be the most correct term to use when we're discussing this with patients or want to bring it up, because I know there's a variety of variations on that. If you could speak to that.
It stands for lesbian, gay, bisexual, transgender, and then if you add on the QI, it would be questioning, intersex, and some people add on an A to that as asexual, because that's something we really haven't discussed. There are definitely asexual people. So those letters sort of get long, and so it typically is LGTB, and then I added a little plus to include all of them. But yeah, again, I think it's just about having that conversation with your patient, and some patients may not label themselves in any way, and that's something else that we should be mindful of, but not everybody wants to have a label on them. So having the conversation, asking the patient, again, what is their pronoun, how do they want to be addressed, what's the name that they would like for us to use, and if there's any, particularly if it's for like a sexual history, the 5 Ps, you really can't go wrong. Always use those open-ended statements. What does safe sex look like to you, and who is your partner or partners? Throw in that S. Don't assume that somebody just has one partner. Make it okay to have, not that it's okay maybe for you, but for the patient to have more than one. That way you can really address their sexual risks. That's really having that conversation and establishing that rapport is how that's done.
Thank you. Another question is managing bed assignments for patients in semi-private rooms. It's something that Bernadette is struggling with in her work situation right now. Any suggestions? I know there's probably many things you can do, but thoughts on that for bed assignments?
Well, I don't necessarily, I work in an ER, so I really don't make, any bed assignment. We don't have any rooms that are not private rooms, but again, you really want to do the right thing for the patient. I guess, that's really the only thing you could do. If you think it would be uncomfortable for a patient sharing a room, then you have to do what's the right thing for the patient. If that means altering the assignment, then that means, I guess, altering the assignment if it's possible. I mean, no situation is completely ideal. I think anything that could be done to show the patient that you're trying to be respectful of their care is a step in the right direction. And even if you can't, even if you could just go to them and say, listen, I really tried, I did this and whatever it is that you did, because I know this is a problem for you. As soon as something comes up that's available, we're going to see to it. I just want you to feel that we're trying to respect your wishes and what makes you comfortable. I think people hear that, just that you're trying, just that you understand and you're trying sometimes is enough.
Yeah, I agree with you. Thanks for that. There's another question from Lisa about, she said she's having a great deal of concern about patients that are having gender reassignment surgery. Are there a large number of people that are choosing this therapy, and what do we need to be concerned about or thinking about with regard to screening in our practices for gender reassignment?
That is a wonderful question. The majority of patients that I have been in contact with choose to not do the bottom surgery. It is very few that actually do that. I'm not saying people don't, but again, if that's part of their surgical history, that's something that you would want to ask. I know I have a medical record where I work. It's already included in the medical record, so if you were taking that sexual history, it would be included in the sexual and surgical histories. But most patients, so trans patients, if it's the ones that I see, may elect to have mastectomies, but a lot of them choose a hormonal route more so. In fact, we have an endocrinologist here in town that does a lot of lectures for us regarding just hormone replacement and, testosterone replacement if it's in females and estrogen in males. And her advice to this is to have them see an endocrinologist refer to an endocrinologist for management. It does not have to be an endocrinologist. It could be anybody that's comfortable managing hormones in that way. That is going to be much more common whenever you do have a woman who's taking hormone replacement or taking testosterone, I should say, in transitioning. Those testosterone levels are not any higher than they are in a normal man. They are synthetic, obviously, but not any higher. So the cardiovascular risk goes up in that female just to the equivalent of that of a man. But to say that there's a whole lot of research that's been done that's shown it to be very harmful, it's not really been shown to be any different from that of a man. The earlier that hormonal transition or hormonal supplementation can occur, usually the better that person is able to pass later on in life. In other words, if you wait until this man is completely sexually mature and has a beard and all of it, it's very difficult, develop the large bones. It's very difficult to then pass for a female later on. But if you start the hormone therapy earlier on, or the gonadotropin releasing hormone blockers early on, and prevent that from happening, sometimes they can pass better as an adult.
Thank you. A comment, I think a wonderful comment here from Cindy, who says that I think we should all be asking everyone, not just people that we suspect that may be transgender or have, or queer or whatever, that we should preface this with, I ask all of my patients the same thing. Do you have sex with men, women, both, and what pronouns do you prefer? And I think that hits it right on the nail, right on the head.
Absolutely. I love that.
Me too.
Absolutely. Thank you, Cindy. That's wonderful. Yes.
There's a question from Lori about specific resources for integrating LGBTQ content into nursing education curriculum. It sounds like, and even went through BSNs, it sounds like you have a training program there at LSU that can assist with that.
Absolutely. She can feel free to email me and contact me and we can discuss that further. In the BSN program, I think to incorporate it in there, we incorporated it into a Senior 2 course right before they were going out, but I would like to change. I don't teach BSN at all. I teach in the BSN to D&P. But in the BSN program, I'd like to start this sort of training in their health assessment. I think that's really where this belongs. But right now it's in the Senior 2. But yes, we can definitely talk more about how to integrate it through a curriculum and the best ways of doing that.
Thank you. Another question, a question from Leanne. In a small community hospital where I work, the triage nurse upon entry asks everyone how the patient identifies themselves and makes bed assignments respectively. Because of this privacy, this information is not disclosed to the other person in the room. Excellent way to deal with that. Thank you very much, Leanne, for sharing that. And what has been the response for those that have gone through some of your training? You had said that you've taken this out to other organizations.
Yes, we've had well, it depends actually. We've done it in workplace environments as well. And truthfully, if you're going and you're giving this presentation, I'm giving the same presentation in environments where people want the training and are asking for the training similar to this one versus people who have been told by their administrator, you need to take the training. And really the same presentation, same speaker, everything, and the comments are quite different. People who want the information and who feel the information valuable tend to rate my presentations much higher versus the ones that are told they have to be there. So it really depends a lot on the audience. Overall, though, I seem to get more positive than anything negative. In fact, one of the statement, and I have it on a quote here in a poster that's in my office, it was from a med school faculty, an older gentleman who, believe me, LGBT was not on his radar whatsoever, and he sat through one of our courses and then at the end wrote on my evaluation, I had no idea that my practice was re-traumatizing my patients.
Thank you so much. We wanted to take a moment here. I think we've gotten through most of the questions, and just to remind everybody about the CE credit available, and I'll turn this over to my colleague at the AANP, Joseph Rise.
Hey guys, this is Joseph with the American Association of Nurse Practitioners. AANP and the Education Department has accredited this presentation for one continuing education credit hour. And there's a very pretty simple process to receive CE credit today. This slide that you're seeing right now outlines the steps in detail. So first, you do want to visit the AANP CE Center. There's an embedded link included. And if you do not have an account already, go ahead and create an account with the CE Center. Please use the same email address that you used to register for this webinar. Use that same email address to register with the AANP CE Center if you haven't already. So once you're on the CE Center, you're going to go to the My Account tab, and if you click on that tab, I'm sorry, you're going to click on the Products tab, and under Products is, I'm sorry, so the My Account tab will have a Products tab, and on that tab, there's going to be this webinar listed. It's titled Delivering Culturally Sensitive Care to LGBT, and I believe on the CE Center, it's LGBTQi patients. Same webinar, so click on that, and you're going to go and click on Steps to Receive Credits, and once you click on that, you're going to be required to enter a participation code. So we ask that you do not share this participation code with anybody who did not attend this webinar, and we have a full list of registered attendees and those who attended the webinar and for how much time they attend, so it's easy for us to tell if somebody is trying to access the credit when they didn't attend the webinar. So the participation code is AANP2684, and then you'll click Submit, And then for this particular CE opportunity, the only thing you have to do is complete an evaluation for the webinar, and then you receive your credit. The next slide shows you a little bit more in detail what the website will look like once you get to the CE Center and you click on the My Account tab and you go to Products, and then that's what's going to be listed. This is just an example. It's a different webinar, but essentially on the screen will be titled Culturally Sensitive Care for LGBTQi Patients. So click on it, click on Steps to Receive Credit, and then under Code 1, or it might say Tracking Code or Participation Code. Sometimes it varies. You'll enter AAMP 2684, click Submit, and then it'll ask you to complete the evaluation, and then once the evaluation is complete, you receive CE credit. So if you have any questions, you can email me directly at jreyes@aamp.org. It's in the chat box there for you. And that's pretty much it.
Thank you, Joseph. So just to let everyone know, if you have any additional questions that Dr. Landry was not able to address today, please send an email to either myself, Cheryl Fattibene, or Tiffany Depew, and our information is there. I know there were a couple questions we did not get to, so I want to make sure that everybody has access, and we will forward them on to Dr. Landry for you. Just to let you know as well, we have an additional Lunch and Learn coming up next month on the science and joy of burnout. There's a registration link for you right there. And again, I just wanted to thank Dr. Landry for her excellent work and great presentation, and for being part of our Lunch and Learn series today.
Thank you.
Thank you, everybody, and that ends our presentation for today.